Thank you, Dr. Prasad. Good morning to all. So I will be speaking on a small part of the anterior segment advancement in the anterior segment pharmacotherapy, and it is I'm going to talk more on the advancements and about our work in the management of fungal keratitis. Okay, so this talk I'll cover the current drug and adjuvant therapies and the newer research, our experience. So as you all know, the first line of drug for fungal keratitis is netamycin, which is belongs to the choline group and binds to ergosterol on fungal plasma membrane. It is commercially available as 5% suspension and is the drug of choice for filamentous fungi. However, according to the MUT1 trial, topical netamycin was found to be superior to topical voriconazole for filamentous fungi, and a major difference was noted if the keratitis was due to fusarium. Also, improved vision-related quality of life is also noted in patients with fungal ulcer who received netamycin. And patients given netamycin had lower risk of corneal perforation. Coming to voriconazole, which is a drug belonging to the azole group, it blocks fungal membrane synthesis by inhibiting cytochrome P450, and it needs to be reconstituted to 1% solution from the lyophilized powder. It works better against aspergillus as compared to fusarium. In the MUT1 trial, they have concluded saying that monotherapy is not recommended for fungal keratitis due to filamentous fungi. And the biggest problem with voriconazole is that even though it shows very low MIC levels in vitro studies, the in vivo results are not consistent. Also, systemic side effects are there with voriconazole therapy. And voriconazole has also been used systemically as oral at 400 mg BG on the first day and 200 mg BD for the next days. IV injection has also been recommended. According to the MUT2 trial, there is no benefit of adding oral voriconazole to topical antifungals in the treatment of severe smear-positive filamentous fungi. The same conclusion could be drawn from another study evaluating the corneal buttons from patients undergoing therapeutic PK, the primary cause for perforation being inflammation. But adjuvant oral voriconazole therapy showed decreased rate of perforation and or need of therapeutic PK in eyes if the keratitis was due to fusarium. Its side effect, it's hepatotoxicity. Coming to the other group, which is the amphotericin B, which is a choline drug which binds to ergosterol on fungal cell membrane and alters fungal cell permeability. It is the drug of choice for candida infection, second line for aspergillus, and it is to be reconstituted to 0.15% drops. Liposomal amphotericin B is also available, though it's a little expensive, but it can avoid the renal toxicity of the routine amphotericin B. Other azole drugs which have been used, there are a couple of reports, or anecdotal reports actually, which include iconazole, fluconazole, ketoconazole, and itaconazole. Ketoconazole and itaconazole, however, are routinely used as systemic medication as an adjuvant therapy. Newer agents include triazoles like posaconazole and ravuconazole, and echinocandins like caspofungin, micafungin, and idursulfungin. Okay, the reports again in fungal keratitis treatment is again anecdotal, and also the biggest problem with these drugs possibly is also the cost. And so to summarize the current drug therapy for medical management of fungal keratitis, we need to first do a corneal scraping and microbiology. And if it is an yeast, we start with 1% voriconazole eye drops. If it is a filamentous fungi, we start with 5% netamycin drops. And based on the culture report, if it is fusarium, you have to add oral voriconazole because that has adjuvant better effect. And if it is aspergillus, we can add topical voriconazole or amphotericin B. And in case of no response to either of this, the last resort, of course, is a therapeutic keratoplasty. Now, antifungal injections are also getting popular more and more. So both voriconazole as well as amphotericin B are being used as interstromal or intracameral injections. The concentrations are described here. However, this study published again from South India said that there is no added benefit of interstromal voriconazole in eyes receiving topical 5% netamycin. In a recent report from again from RP Center, they have shown good efficacy to intrastromal netamycin formulation in cyclodextrin when it is injected into the stroma. It causes good reduction in the fungal keratitis thing. So as you can understand, there is an unmet need here, as natamycin has multiple drawbacks. It is fungistatic, it is poor penetration across corneal epithelium, and high tissue binding leading to poor bioavailability. It is insoluble in water and used only as topical suspension and cannot be administered by any other route. And compared to bacterial ulcers, fungal ulcers are more difficult to treat with poorer outcomes. So we chose to work on peptides, which are an nanomolecule. The cell-penetrating peptides, these are short-chain amino acids, which act as can carry a cargo across the cell membrane without causing that disruption. It is usually positively charged non-viral drug delivery system, which can be both energy dependent or independent. It is non-toxic and biocompatible, and exact mechanism of action is not known. So we created a conjugate of cell-penetrating peptide with natamycin, which we called as the TAT2-NAT, and following conjugation with the TAT2, natamycin, which is otherwise not soluble in water, became soluble in water. Now here are the in vitro results. So here these images show the human corneal epithelial cell lines. As you can see in the last image on the lower panel, you can see that excellent internalization of the TAT2 natamycin into the human corneal epithelial cells in vitro, which indicates that the TAT2 has been able to carry the natamycin into the corneal epithelial cells, whereas in the only natamycin group, the natamycin has not been able to penetrate into the corneal epithelium. The similar result was also seen when we exposed TAT2-NAT to fungal filaments. These are the Fusarium solani filaments in vitro, and you can see here there is significant fluorescence coming out of the fungal filaments in the last two images down. There is no penetration of natamycin into the fungal filaments. And here, when we expose the human Fusarium infected human corneal epithelial cells to the TAT2 natamycin, we could see complete inhibition of the fungal filaments, as is noted in the last image down. So after having gotten such good, excellent results in the in vitro study, we planned the animal study. So the first purpose of that was to establish a mice model of Fusarium species keratitis, followed by evaluation for the antifungal efficacy, and subsequently to look for the drug permeability across the intact corneal epithelium in the rabbit eyes. So this is the mouse model that we created. These are mice which are first immunosuppressed, and then the right cornea is scored using a 26 gauge needle, and the fungal suspension is applied on the cornea, and the eyelids are rubbed for a few seconds. And we tried 3 different concentrations of fungal spores to figure out which would be the appropriate dosage for creating the keratitis. And then the keratitis was graded after 3 days of induction based on this slit lamp grading. The grades 2, 3, and 4 are the eyes with the proper fungal keratitis and infiltrates. So when we evaluated the 3 different concentrations of colony forming units, we found that 10 to the power 5 CFU per 5 microliter was the most effective in creating keratitis. So this particular concentration was used for further studies. So these are the various slit lamp grade of keratitis that were used, and as you can see here, grade 2, 3, and 4 show significant keratitis, and these grades were included in the further study. So then after induction of the keratitis, the right eye received various drug groups, various drugs as per the grouping, and the topical formulation, drug formulation was applied 6 times for 3 days, 10 times for 3 days, and then 6 times for another 3 days. So at the end of 6 days of treatment, the slit lamp grading was done and animal was sacrificed. And so this is a bar graph which shows the reduction which evaluated the efficacy of the treatment with the drugs. And as you can see here in the TAT2-NAT group, there is significant improvement in the grading of the keratitis and improvement in the clinical scores as compared to natamycin alone. The peptide alone also, TAT2 also showed some amount of antifungal efficacy. And when it comes to complete resolution of the keratitis, we can see that only 12.5% animals in the natamycin group had complete resolution of keratitis, while in the TAT2 natamycin group, in the 200 micromolar, it was 37.5%, and in the 100 micromolar, it was about 45%. And these are some of the images to demonstrate the efficacy. You can see the top panel is the pre-treatment images, and the lower panel is the post-treatment images. You can see good results with the TAT2 natamycin, both in 200 as well as 100 micromolar concentration. Next was to prove that being peptide conjugated natamycin, the peptide, whether the peptide is able to carry the natamycin across the corneal epithelium. So these rabbits were taken. The right corneal epithelium was debrided. The left corneal epithelium was left normal. The drug was applied 4 applications, once in every 15 minutes, and at the end of 1 hour, the concentration of the drugs were evaluated both in the cornea, aqueous humor, as well as in the vitreous. And the left chart is the eye, the left eye, which has the intact epithelium. Here you can see, compared to natamycin, the TAT2 penetration is significantly higher. TAT2 natamycin penetration is significantly higher, both in the cornea as well as in the aqueous humor. The same thing is noted in the right eye, where the epithelium was debrided. Again, though natamycin penetration improved following removal of the epithelium, but there was still a significant difference in the concentration of the TAT2 nat as compared to natamycin, both in cornea as well as in the aqueous humor. And we also exposed, this is another experiment which we did, we exposed the fungal fusarium spores to the drugs. As you can see in the third panel line of images, you can see significant shrinking and damage to the fungal spores with TAT2 natamycin as compared to natamycin alone. So to summarize, TAT2 natamycin showed better antifungal efficacy as compared to natamycin alone in our murine model. The peptide alone also showed significant antifungal activity. Also, higher penetration of TAT2 nat was noted in the cornea and aqueous humor in vivo as compared to natamycin alone, and this difference was statistically significant. And thus, to conclude, TAT2 CPP conjugated natamycin appears to be a promising strategy for delivery of natamycin with increased penetration and effective antifungal activity. These are the 2 papers that we published, and I'd like to conclude by acknowledging my team with whom we have been working, essentially from IIT Delhi and the National Institute of Biological, and also Dr. Pujari from the Breach Candy Hospital. Thank you very much for the opportunity.
Thanks, Dr. Sushmita. Now I call upon Dr. Bhupesh for keratoplasty with cataract in different situations. We may take one question only by the time in between his preparation. If any question, please.
Any questions? Yes, please. Yeah, we are trying to do the technology transfer, so we are in talks with the industry. So this the whole work was done without any participation of the industry. It is purely an academic thing. So now we are going to the industry and talking to them, but then there are a lot of regulations and stuff which are there. So might take some time, but we are on it.
So it acts as a vehicle for the